जी 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 जी
चलो, thank you. Thank you all the organizers and the Pakistan Society of Neurology. So without further wasting time, since the time allocated to me is about 20-25 minutes, I'll quickly move to the next slide with this intro of my department. This is the Department of Pediatric Neurology last year on International Epilepsy Day, which is just 48 hours away from today, decorated with the purple balloons. So before actually describing the exact first-line drugs for epilepsy or epilepsy syndrome in children, just a quick recap of the epilepsy diagnosis and some of the prominent and pertinent feature regarding the epilepsy diagnosis of epilepsy syndromes. Generally, we used to classify as in adults all the epilepsy syndromes with the help of clinical history and its etiology, and try our level best to classify according to ILAE syndrome classification. So as it's described by before my previous speakers, the history is crucial, and one should always keep in mind about all these features in history before labeling any child with epilepsy or specifically any epilepsy syndrome. The history is the key factor before. However, one should always keep in mind following points about support of the diagnosis of epilepsy, in contrast with some of the mimicking differential diagnosis, for instance, like pseudo seizures or breath holding spells or any movement disorder. Like they may occur in a stereotype fashion during the day and night, and most of the times trauma is a feature in epileptic seizures. So followed by a good history, one should always spend some time in the clinical examination. For instance, many of the neurocutaneous syndromes, as mentioned in this particular picture, can have a strong association with one or other epilepsy syndrome. For instance, neurofibromatosis type 1, type 2, Sturge-Weber syndrome, or any other neurocutaneous syndrome. They have a strong association. However, still there are some investigations which have some role in the diagnosis and classification of epilepsy, starting from ABGs, which may be required for any underlying neurometabolic syndrome, all the electrolytes to exclude possibility of hypocalcemia or hypoglycemia or hypomagnesemia, and of course to exclude any underlying liver and renal abnormality. But the crux of the slide is EEG and imaging, but I'm sure these two have already been described by previous speakers. So I will not go into the details of importance of EEG and imaging of the brain in childhood epilepsy. However, they are really important in the future prognosis, classification, and for defining any specific epilepsy syndrome. Like in this slide, you can see the calcification in case of Sturge-Weber syndrome. EEG were always very important for classification, prognosis, and discontinuation of epilepsy, anti-epileptic drug. Recently, the importance of genetic diagnosis and genes are really important, and in all developed world, the epilepsy panel are perhaps one of the routine investigation in the initial evaluation. After a good history examination, one should always try to spend some time for the underlying etiology. And in developing countries like Pakistan, hypoxic ischemic encephalopathy and infections are perhaps the one of the commonest reason for epilepsy, followed by vascular, genetic, and brain malformation, which are per se because of the underlying genetic reason. According to ILAE classification, I'm sure described before, either from the basic version or the expanded version, there is importance of epilepsy syndromes. The reason why this is important, because there are many specific epilepsy types and seizure types which are not addressed either in the basic version nor in the expanded version of classification. So this slide is perhaps one of the most important slide in the epilepsy classification, because it not only explains the epilepsy syndrome, its etiology, but the comorbidities as well. Epilepsy syndromes are because of a specific epilepsy type, is because of its etiology, e.g. feature, as well as age of onset. Differential diagnosis is another important. Once you take a good history, clinical examination, and end up with a set of specific investigation, still you should keep in mind some sort of differential diagnosis in those children. And it's really important to differentiate between truly epileptic seizure, epileptic movements because of the epilepsy, or per se because of non-epileptics. For instance, in these two slides, you can easily decide these are not epileptic seizures. These are either movements or conversion or tics. So the next important is, are you dealing a child with really intractable seizure, or something which is either, according to the new classification, called as self-limiting or benign seizures? Are you able to see these videos, Dr. Malik? So if you are encountering a child who has really challenging drop attacks, you should be really face a challenge to manage that particular child, in contrast with a child who has either self-limiting disease or just idiopathic focal seizures. Because intractable seizures are the one who may end up with significant brain injury, which may end up with a fracture. These are some of the salient features in case of pseudo seizure, in which pelvic thrusting, prolonged, bizarre movements without any alteration in the conscious level are the usual feature. So at this stage, you should be able to decide that you are evaluating a child who has epilepsy. And before the start of any anti-epileptic drug, you should be clear that this child has epilepsy, its specific epilepsy syndrome, and whether according to the ILAE classification, is this a milder version or a type which has some sort of intractability. The general principle is treat 2 or more seizures, with following few exceptions, which are either status epilepticus, or with the help of EEG, you may decide you are dealing a child with juvenile myoclonic epilepsy. In children with abnormal radiology or abnormal clinical examination, it may be a case of cerebral palsy or degenerative brain disorder. In all these situations, perhaps you should not wait for the second epileptic attack or status epilepticus. So this is the actually topic assigned to me by the organizers, the selection of anti-epileptic drug in children. So setting this ground, I would like to start from the management of a child who had first unprovoked seizure and selection of appropriate anti-epileptic drug. Apart from the anti-epileptic drugs, there are few more options available for children as well. And these are vagal nerve stimulation, epilepsy surgery, and ketogenic diet. I will spend a major portion of my talk on anti-epileptic drugs. However, the last two slides would be on these few relatively new modalities, at least in the developing countries. So these should be the considerations for the selection of anti-epileptic drug in any child who has been diagnosed as epilepsy after a first unprovoked seizure. So the drug should be according to the ILE classification. It should have a relatively low side effect profile. One should be aware about the mechanism of action, its interaction, its mode of elimination, pharmacokinetics, any need for the laboratory monitoring, comorbid condition of the child, and last but not the least is the cost. Since we are living in a developing world with a resource limited setup, we should always keep in mind this point, because these are the drugs a patient has to take for at least 2 to 3 years. The principle of management is always start with one specific anti-epileptic drug, which is syndrome specific or the type specific, build it to a level where it controls seizures, and then you should taper after a 2-year seizure-free period. In the selection criteria, individual circumstances really matters. And these are long-term safety, tolerability, of course, seizure freedom, interaction potential. Gender is really important because there are few drugs which have some teratogenicity, and though not really important in pediatric practice, however, in adolescent children, in our setup, there are girls who have been married somewhere around 16, 17, and still being looked after by pediatric neurologists. Specific body type, learning status, and of course, weight is a real consideration. Mechanism of action is really important before keeping in view the comorbid conditions. This is a brief list of anti-epileptic drugs available in Pakistan, and I'm sure in the region as well. I have divided them into relatively older version and relatively newer group of anti-epileptic drugs, though these newer ones are not really new in many of the developed world. However, this is a small list of some specific molecules which are not historically characterized as anti-epileptic drugs, and these are intravenous immunoglobulins, steroids, pyridoxine, and ACTH. So coming back to very specific selection of drugs in some specific epilepsy groups, this is perhaps one of the most important slide where you may select one of the first-line drugs for focal seizure, which are generally carbamazepine, followed by valproate sodium and levetiracetam. In case of poor control, one may switch to the second-line drugs or the last resort. However, one should keep always in mind that the principle would remain the same, and that is go slow and go low, which means you should start with one appropriate drug for specific epilepsy syndrome, build its level to a stage where it gives total seizure freedom, or one may develop side effect of that particular drug. In development of side effect, either you switch to the next first line drug, or you may decrease if it was otherwise clearly control the seizure, maybe 10 to 15% from that particular drug. As far as the generalized seizures are concerned, first line drug for generalized seizure is valproate sodium, followed by lamotrigine, and in a group of second line drug, it's topiramate, and the list is quite longer. Absence seizure really important and challenging. Valproate is as usual drug of first choice, followed by ethosuximide. However, ethosuximide is neither registered in Pakistan nor available in Pakistan. So my advice to my trainees and colleagues is always, if you are unable to control absence seizures, absence attacks, then you should immediately switch to lamotrigine. And in the initial few months, you may have a cover of valproate and build lamotrigine during those few months, and then maintain that level of lamotrigine which gives seizure freedom, and maybe withdraw valproate sodium. But after failure of these two excellent drugs, which gives maybe able to give you seizure freedom in up to maybe 80 to 90%, the next choice may be from one of this second or third line drugs, which includes topiramate and benzodiazepines. This is one of the classical pediatric infant syndrome called as MES syndrome, a combination of infantile spasm and this classical EEG showing hypsrhythmia. The diagnosis is really important and challenging for the general practitioner as well as for the pediatrician, because these subtle movements are generally missed by the initial evaluation. But if you are able to recognize, diagnose right at outset, overall prognosis is very good. Because luckily for the past year or so, Vigabatrin has been a registered product in Pakistan, apart from many other options which include oral prednisolone along with benzodiazepine, levetiracetam, topiramate, and nitrazepam. Valproate may also be considered another choice in case where one is unable to control seizure with the remaining drugs. However, our experience for the past 1 year is very good with Vigabatrin. Since it's a registered product now, so I will give one more slide to Vigabatrin. Infantile spasm is really challenging when they are combined with tuberous sclerosis, which is a now called tuberous sclerosis complex, in which these children have not only seizure, but also involvement of heart, kidney, lung, and of course skin, because it is one of the neurocutaneous syndrome, as I mentioned before. So as I mentioned, Vigabatrin was a recently approved drug in Pakistan, however, approved globally, not only in Europe, USA, but in many of the Far Eastern countries as well. It is indicated as a monotherapy from 1 month onward for children with infantile spasm, and drug of first choice for children with tuberous sclerosis complex. The only reservation is with the use of Vigabatrin is its potential side effect of fuel field defect, which is loss of peripheral vision. However, it's fairly safe in children if vision is safe in the initial, is a normal in the initial evaluation for next 3 to 6 months. However, response is excellent for the past 1 year in our experience after its approval. The next syndrome I would like to discuss in relatively older children is juvenile myoclonic epilepsy, which is again quite common in teenage girls. The good thing is that generally these young girls are seizure-free in the rest of the day. However, neurological examination and the normal imaging is really challenging for the pediatrician or a pediatric neurologist or even adult neurologist who is looking after these girls, because in the rest of the day, since they are seizure-free, so one may not have this luxury of actually witnessing this seizure. So video recording is really helpful in these children. So if one is smart parents are able to record the videos, it's really helpful for the diagnosis. EEG is again very helpful because burst of high voltage against a normal background is pathognomonic for juvenile myoclonic girls who has early morning myoclonic jerks. They show excellent response with valproate sodium. If the children develop any side effect or drug is really leading to hair fall or obesity or something like thrombocytopenia, then levetiracetam is another good option. However, the point is one may take this drug for the rest of the period, rest of the life. Photosensitive epilepsy, again, a type of specific epilepsy, which is because of the recent change of global pandemic, when children are bound to have their classes on the screens and the mobiles, on the laptops, is again a challenging thing. So photosensitive epilepsy is really challenging for the pediatrician as well as for the pediatric neurologist, adult neurologist. Again, valproate sodium is a drug of choice, followed by next options. Couple of slides about the new modalities, which are ketogenic diet as well as this CBD oil. These two group of management are, of course, for those in which we are unable to control seizure with the first line or the second line drug, reserved for maybe up to 20% children which are drug resistant. We have developed in our unit this small booklet for the parents' guideline, because it's not easy for the family, apart from the child, not easy for the mother to understand how to develop, how to prepare, and how to cope with this very specific diet. Though being prescribed and used in the country for many other aesthetic reasons, however, use in pediatric epilepsy syndromes is not very, I must say, common, but getting popularity, at least in specialized pediatric neurology centers. Response is very good. Since we established this service at Lahore Children's Hospital for the past almost 3 years, our data is very supportive for the continuation of this diet, though challenges are always there. Like all the drugs, of course, all these anti-epileptic drugs have their side effect profile as well, starting from the gingival hyperplasia with phenytoin sodium, and the drug eruption, drug rash with any of the anti-epileptic drugs, but commonly with valproate, carbamazepine, and lamotrigine, and many other common side effects like thrombocytopenia in case of valproate sodium, and many other drugs like hyponatremia in case of oxcarbazepine. So after selection of, as I mentioned you before, good appropriate anti-epileptic drug for specific epilepsy syndrome, and if child remains seizure-free for the next 2 to 3 years, the next important consideration would be discontinuation of anti-epileptic drug. Again, it's really important that one should not show any hurry in discontinuation, because a 2 to 3 year seizure-free period with normal EEG is the basic step. However, individual circumstances may allow the physician who is looking after the child to extend this protocol up to maybe 4 or 5 years or even more, because individual circumstances are really important apart from the specific protocol. However, normal EEG is mandatory. The last slide is perhaps one of the most important component, which is status management at home. Because whenever you diagnose a child with epilepsy, so one should guide the family, guide the parents about any status which may encounter at home, because that status may be life-threatening as well, or maybe brain damaging if not led to that level. So parents' education, family guidance is really important. Options available in Pakistan are diazepam suppository, midazolam, intranasal midazolam in case family is able to request this drug from outside Pakistan, and intramuscular midazolam. So this parents' education is really important and really requirement of the day. And at Children's Hospital Lahore, we have developed these small brochures and epilepsy booklets for the education of the families. Couple of slides about some of the future options regarding epilepsy management, its initial management, and these includes vagal nerve stimulation, some of the newer anti-epileptic drugs which are in the pipeline, epilepsy surgery, I'm sure it's already in the pipeline, at least in AKG, stem cell transplantation, neurostimulation, gene therapy, and not DBS, which is done by neurosurgical colleagues. So I would conclude with this last slide. Epilepsy is one of the commonest neurological disorder. Diagnosis is always a good history. One should always try to classify according to ILAE classification and try to reach to epilepsy syndrome. Correct diagnosis and classification is the hallmark for the good management. And anti-epileptic drugs are the mainstay of treatment in up to 70 to 80% of treatment with a 2 to 3 years seizure-free period. Thank you very much. This is the Children's Hospital and Institute of Child Health. Thank you very much. I'll be happy to answer.